diarrhea evaluation. The first step over here is see whether mother is understanding the definition of diarrhea. Three leaves close stools in a day, taking the shape of the container is diarrhea. And duration less than 7 days, you call it acute. More than 14 days, you call it persistence or chronic. So the mother will say this, look, my daughter, my son, she is having purging for now, yeah, few months longer, even years. This is not the fact. You take the history objectively and you break the days and you'll be finding it's not the months. It is interrupted recurrent sort of diarrhea. In between, there are days which are normal. So diarrhea-free days. So commonest cause over here is the viral diarrhea. Respiratory infection is common accompaniment. Maybe pneumonia, throat infection, maybe concomitant asthma is there. So see those things, count respiratory rate, see the throat, and your look for the features of wheezing, and treat those tissues along with oral zinc supplementation, and and your food known to help useful in diarrhea like the pectin of unripe banana, chicken, and your other suji based formulas there, maybe lactose free milk and others, soya based, all this and that. They are used in refractory difficult cases, long standing cases, and then so give 1 feet more and wait for the resolution of diarrhea for by 3 to 7 days. You need to address the other respiratory issues. Otherwise, most of the time you won't be able to healing of diarrhea. So, and the blood in the stool, but the visible blood in the stool or microscopic RBC, that's invasive diarrhea. Commonly in those cases, Shigella, dysentery, and rarely the others like invasive E. coli, yeah, jejuni, Clostridium jejuni, your Enterovirus latica, and Cryptococcus, and few more uncommon pathogens. So, and in- go for investigating those and treat as per your local susceptibility. Maybe fast drug, maybe Shigella. So give one anti-Shigella medications, maybe Penicillin or so, and see 2 to 3 days. If this response responded, then it is Shigella. Then if it is not low grade diarrhea, little bit of abdominal bloating, not high rate of purging is maybe E. coli and is enterostomatica. So treat those cases with metronidazole. And E. coli enterostomatic infection is more common in a little bit grown up child. Shigella in the younger kids. And then very rarely you will encounter the irritable the inflammatory bowel disease, Crohn's, and ulcerative colitis. Very rarely you will see those things. Those cases should be evaluated in different way. They have recurrence of the colitis, and there are blood in the stool, growth failure, and other issues. They need to be biopsied, then sent to appropriate place and person. Rarely you have other entities like cystic fibrosis, celiac disease, other malabsorptions, vitiligo, and plenty of other issues, causing sensitive enteropathy, and so forth. They have excess fat in the stool, you know, and then if you do the biopsy, you'll get the total or subtotal villus atrophy. Gluten-free diet is curative in some of the cases, and this diagnosis can be helped by endomysial antibody, and cystic fibrosis is diagnosed by the sodium or chloride test in the sweat chloride in the sweat, and 60 and 70 per day, etc. So they're not that common, but possible. There, if you cannot accomplish these things in the primary setting, you send him or her in a tertiary setting. So immunodeficiency state not that common again. Congenital immunodeficiency. If you suspect very difficult refractory, but don't dwell refractory if you have the recurrence in between 2 to 3 days gap between the second episode. It's not continuous on diarrhea or dysentery. Don't take it as recurrent refractory, and then If it is the case, you can go for the congenital immunodeficiency panel, send him to the appropriate place.